Treatment of diabetes mellitus. Glucose occupies a central position in metabolism as the predominant substrate for energy production. Cells receive their supply of glucose from blood, and control mechanisms ensure that the blood glucose concentration remains within narrow limits. Glucose enters the blood by absorption from the gut and from breakdown of stored glycogen or gluconeogenes is in the liver. At physiological concentrations, glucose is transferred from the blood into cells almost entirely by active transport. In most tissues, this transfer is dependent on the action of the polypeptide hormone insulin. Insulin is a protein that is secreted rapidly from the B cells of the islets of Langerhans in the pancreas in response to a small rise in blood glucose. And its secretion is inhibited by a fall in blood glucose. Insulin consists of two peptide chains, A and B, connected by two disulfide bridges. In the B cell, insulin aggregates into hexamers with zinc, and after release from the cell it dissociates into dimers and eventually into the active monomeric form. The presence of nutrients in the small intestine stimulates the release from gut endocrine cells of peptide hormones called incretins, which promote insulin secretion. The principal incretins are glucose-dependent insulinotropic peptide, GIP, secreted by the upper gut, and glucagon-like peptide 1, GLP-1, which is released from the distal gut. Release is triggered by neural signals from the upper gut and direct interaction of nutrients with the secretory cells. GLP-1, glucagon-like peptide 1, has several actions that regulate glucose homeostasis. Enhanced glucose-dependent insulin secretion incretins are probably responsible for about 60% of the insulin that is secreted in response to a meal. Inhibition of glucagon release, prolonged gastric emptying, promotion of satiety by an action on the hypothalamus. The actions of GLP-1, glucagon-like peptide 1, are brief as it has a very short plasma half-life of 1 to 2 minutes due to rapid degradation by dipeptidyl L-peptidase 4, DPP4. Insulin is secreted into the blood under fasting conditions, with pulses every 10 to 14 minutes, and as lower cycle of release every 105 to 120 minutes. In response to a rise in plasma glucose, both the actual concentration and the rate of change, there is a superimposed biphasic pattern of insulin release. The first phase of release occurs within seconds, peaks at 3 to 5 minutes and lasts for about 10 minutes. This is achieved by the release of a small pool of insulin in secretory vesicles. The second phase of release is more gradual, rising to a lower peak than in phase 1, and is due to synthesis of new insulin. Insulin secretion from pancreatic B cells is modulated by K+ channels in the cell membrane that are sensitive to ATP, adenosine triphosphate. The CAP, ATP-sensitive potassium channel has subunits known as sulfonylurea receptors, SURs. Various isoforms of which act as regulatory proteins in the response to ATP, adenosine triphosphate, in different tissues. First-phase insulin release is triggered when glucose enters the B cell via the GLUT2, type 2 glucose transporter, and undergoes glycolysis with generation of intracellular ATP, adenosine triphosphate. Activation of the SUR1, type 1 sulfonylurea receptor isoform by ATP closes the CAP, ATP-sensitive potassium channel, which reduces membrane K+ efflux and depolarizes the B cell. Depolarization opens voltage-gated L-type Ca2+ channels in the cell membrane. And an influx of Ca2+ ions into the cell triggers second messengers that lead to exocytosis of insulin granules. In addition to glucose, many other factors influence insulin secretion. Peripheral tissues express specific cell surface insulin receptors that are linked to a tyrosine kinase, insulin receptor kinase. Stimulation of these receptors leads to translocation of the GLUT4, type 4 glucose transporter to the cell surface, allowing glucose uptake, and activates pathways involved in glycogen synthesis, glycolysis and fatty acid synthesis. Metabolic effects of insulin include the following: glucose metabolism, promotion of active transport of glucose into cells, particularly in skeletal muscle and adipose tissue, accompanied by K+. Insulin enhances storage of glucose as glycogen in liver and muscle and inhibits the breakdown of glycogen, glycogenolysis. Insulin also inhibits gluconeogenesis from amino acids in the liver. The overall effect is to increase glycogen stores. Lipid metabolism, reduced plasma-free fatty acids and increased adipocyte triglyceride storage. Insulin increases hydrolysis of circulating triglycerides from lipoproteins by enhancing the activity of lipoprotein lipase, and promotes fatty acid uptake by adipose cells. Glucose entry into adipocytes provides glycerol phosphate for esterification of fatty acids to triglycerides. In adipose tissue, insulin inhibits lipases and prevents triglyceride breakdown. Protein metabolism, inhibition of the catabolism of amino acids in the liver and increased amino acid transport into muscle with enhanced protein synthesis. Several hormones inhibit the anabolic actions of insulin, particularly on carbohydrate metabolism, although effects on protein metabolism vary. These include glucagon, growth hormone, cortisol and catecholamines. Most of these hormones are released in stressful situations that require the breakdown of glycogen reserves to provide energy. Exercise 5.1. Answer the following questions. How does glucose enter the bloodstream? What does this transfer depend on? How does the mechanism of insulin secretion work? What are incretins responsible for in the body? How is glucose homeostasis regulated? What process occurs in response to an increase in plasma glucose? Can you describe the mechanism of insulin secretion? What are the metabolic effects of insulin? What is responsible for the anabolic actions of insulin inhibition? Exercise 5.2. What do you know about diabetic ketoacidosis? Read the following patient's letter. In pairs, discuss possible recommendations. I still appear to be struggling a bit with the diabetic ketoacidosis, and can't seem to get rid of it. The gymnema and other bits are helping to keep the blood glucose level, BGL, reasonably under control, but I'm still not coping with the diabetic ketoacidosis, DKA. At my last diabetes checkup, my BGL, blood glucose level, was okay at 99, but my ketones were 0.8. In order to control the symptoms of the DKA, diabetic ketoacidosis, i.e., liver pain, lactic acid pains in legs, sore kidneys, and the breathing difficulties that follow, I've had to take a glass of water with 1/2 teaspoon baking soda and 1/4 citric acid, or lemon juice, at a rate 4 times between midday and through the evening. I've been taking this amount for about 2 weeks now. Unfortunately though, I'm getting edema in the ankles, and feel as if I have pressure in the head. In addition, my ears are ringing, I feel very woozy, and like I'm not quite here, fuzzy in the head. I'm also shaky, and finding it difficult with my balance, bump into things like walls, drop things. I've added 1/3 teaspoon potassium bicarbonate tonight, just in case the amount of baking soda I've been taking has depleted my potassium levels a bit. This seemed to help for about 10 minutes for head symptoms, but they have since returned. I'm currently drinking about 3 liters of water a day, but wondered if this was sufficient since I seem to still be incredibly thirsty. I'm still on no carbs, and on a 3 to 5 days respite from the majority of supplements as recommended, but I'm at a loss what to do about the DKA, diabetic ketoacidosis. If I don't take the baking soda mix every day 4 times a day at least, the DKA, Diabetic ketoacidosis symptoms are unmanageable. Is there a chance the DKA, in time, will subside? Do you have any suggestions on how I can at least minimize some of symptoms? Thanks for any advice. Mary. Exercise 5.3. Write a letter to Mary. Use the following phrases. Dear Mary, I'm sorry to hear that you're still struggling with diabetic ketoacidosis, DKA, despite your efforts to manage it. Firstly, it is positive that, however, the presence of ketones, I can offer you some general advice here or some suggestions that may assist you in minimizing DKA symptoms. Wishing you the very best in your journey toward better health. Sincerely.